Okay, so welcome to NUR 188 Unit 5 Class 2 Zoom session. So as you know, this week's topic has really focused around respiratory. So there's lots of cool stuff that go along with respiratory. But before we get to that, I just want to clarify something in relation to the online class worksheets. I did put up an announcement on Plato this morning about that. Those were designed essentially as tools to help you go through the class PowerPoint. They're not assigned for points. They don't count for a grade. That being said, I strongly encourage you to do them and go ahead and upload them in the special Dropbox that is there. When you upload it, I will review your work. I give you personalized feedback. So thank you to the two people that already uploaded theirs. They could check out their feedback on there if they haven't done so already. But it's there to kind of keep you in tune and keep you in check and keep you engaged with the material. So while it doesn't count as a grade, I've been doing this for a long time as an educator. I think it'll definitely be reflected on exam grades if there's people that aren't doing them. So, you know, to your own peril, don't do them, but I strongly encourage you to do them and upload them so you can get that feedback. Okay, let's go ahead and start by reviewing today's quiz. So, looking at the first part of the quiz, which was related to matching. And again, these may not be in the order in which you had them on the quiz because of it scrambling, but this is what the content was. So assessing gag reflex is priority after this diagnostic test. That was bronchoscopy. So with a bronch, remember they're going to numb the gag reflex so they can get the scope down there. So it's very important post-bronch that we make sure the patient has a gag reflex before giving them anything to eat or drink, but also be concerned that if they don't have a gag reflex, there's always that risk of aspiration even on their own saliva. So assessing gag reflex is really a priority for those patients. PCO2 result of 39 millimeters of mercury on an ABG. That is considered a normal finding. If you remember your range, your normal range for PCO2, it's 35 to 45. Nervousness and anxiety are associated with this medication. This is your phenylphrine, so this is your decongestant. Okay, things similar to like Sudafed, your Afrin, that sort of thing. Nervousness and anxiety are very common side effects with those, any type of decongestants. Rinsing the mouth after use is priority to prevent thrush. This one was fluticasone because fluticasone is part of the glucocorticoids. So while it is a good practice to rinse your mouth out after any type of inhaler, whether it's an MDI, DPI, or even a nebulizer, it is a priority after your steroids to prevent that thrush because it changes the normal flora and they can actually have yeast growth in the mouth, and that's what we call thrush. And the last one at the matching was this medication smells like rotten eggs. And that is your acetylcysteine, which is also known as mucomist. We talked a little bit about mucomist even prior to this unit because it is also in a liquid form. It is the antidote for acetaminophen toxicity. It is also given as an inhaled medication, as a nebulized medication. It is a mucolytic to help really thin out those secretions, but it smells something awful, okay? So moving down on the quiz, patients with COPD are at higher risk for oxygen toxicity because it can suppress their drive to breathe. That is true. Part of the physiological changes of COPD is their drive to breathe is going to be based on CO2 levels, high CO2 levels. So when we increase their oxygen, it actually drives their CO2 levels down. It makes them become very lethargic and non-responsive, and then they quit breathing. So that is considered oxygen toxicity with those patients. So that was true. Priority assessments prior to administering an albuterol nebulizer include auscultation of lung sounds, respiratory rate, oxygen saturation, and heart rate. That is true. All of those things, you're giving a breathing treatment, so respiratory assessment is critical. It's also important to assess heart rate because albuterol causes an increase in heart rate, tachycardia as a side effect. That will also determine whether or not we should be giving that medication, because if the patient's heart rate is already in the high 100s or 110s at a resting standpoint, and now we're giving that albuterol nebulizer, that can raise it even higher. And we get concerned if their heart rate is sustained up at a certain level for too long because it decreases cardiac output. Patients with acute exacerbation of COPD are likely to exhibit which acid-base imbalance, and that would be respiratory acidosis. We're going to talk a little bit more about ABGs in today's Zoom session, so we'll kind of get into that a little bit more. Assessing blood glucose levels in COPD patients with diabetes mellitus is important because they are at higher risk for hypoglycemic episodes. That is false. Your COPD patients are likely treated with your steroids, and particularly if it's an exacerbation, there is an IV or PO steroid being given. That will cause hyperglycemia. So that's what we need to be watching for in these patients. It's also why these patients are often prescribed blood sugar checks, AC and HS, with a sliding scale coverage, even if they aren't diabetic, but because of this side effect. And the last one, initiating antibiotic therapy is priority for a patient with pneumonia who has a dry, non-productive cough. That is true. If you think back in the capture and you look back in that, one of the things we talked about is a key principle is really getting that specimen before you start the antibiotics. However, in this case, in this question, they have a dry, non-productive cough. And if we wait to try to get a sputum specimen, try to give them, mucolytics or something like that, if it's dry, there's really nothing there. There's nothing for us to truly culture. If we delay treatment with that antibiotic, we may be missing the boat. They may actually, it increases their risk of mortality. So in a perfect world, yes, I want to get that specimen. In this particular scenario, it was a dry, non-productive cough. There is no specimen to be had. And again, we don't want to delay care, because if they're at the point where they're going to require hospitalization, they failed outpatient treatment. We're looking at IV antibiotics. And if we're not quick to respond, that can have the patient experience a very poor outcome. Okay. All right, so I know there's some questions along the side. I'm going to go ahead and kind of start what I was going to cover and then kind of hit the questions towards the end, and we'll make sure we cover everything. So the one thing I want to start with and encourage you to consider is when you're talking about a respiratory patient, not to look at it in silos, okay? I don't want you to study this material like this is what we do for an asthma patient, and this is what we do for a COPD patient, and for a PE patient, and somebody with pneumonia, somebody with CF. All of those disorders have a problem with oxygenation, okay? So when we start talking about patient care in relation to what I like to consider an oxygenation disorder, there are a lot of interventions that are going to apply across the board, regardless of what your patient's medical diagnosis is. So as you're reviewing these concepts, it's really important to think about it that way and really understand the different nursing care and the nursing interventions. Not only, okay, I should do this for a respiratory patient, but why should I do this for a respiratory patient? What is that faculty level rationale behind that intervention? Why are we doing this? Because that's going to help you really kind of take care of these patients. Now, as I've always said, in your plan of care, there must be interventions related to treating the cause of the problem. And that's where you kind of differentiate between the asthma and the pneumonia and the CF and the COPD, treating the underlying cause. But oxygen therapy is oxygen therapy. Coughing and deep breathing is coughing and deep breathing, regardless of who you're doing it for. So understanding the intervention and understanding the rationale behind it is important, but also know that it applies to multiple types of respiratory patients. So as you're reviewing and studying, I want you to really keep that in mind. Okay, so let's go back to the basics. And those of you who came from 186 with Mrs. Brenchley, you guys remember last semester, Unit 5 was also oxygenation and perfusion. So if you think back to your foundations course and that unit on oxygenation and perfusion, your fundamentals textbook has a lot of good information, okay? ATI does cover the foundation stuff superficially, but if this is an area where maybe last semester it didn't go as well for you, maybe that was one of the more challenging exams, you definitely want to get back into your foundations book and review those concepts, because a lot of what I'm going to talk about today and a lot of what is in this unit is reinforcing foundational concepts and looking at them in relation to a med-surg disease process. So if you think about some foundational concepts and we look at respiratory assessment, your focused respiratory assessment, and what your components are going to be. Okay, you all know how to do a focused respiratory assessment. You know you're looking at your patient's generalized color. Hopefully they're flesh toned or pink and we're not pale or cyanotic. That's going to indicate a problem. But you're looking at their respiratory rate, okay, the rhythm, the depth of their respirations, their effort, both at rest and with exertion. You know, you can have somebody who is short of air, and it's very important to differentiate. Are they short of air at rest? Or are they okay at rest, but they become dyspneic on exertion? You need to differentiate between those two. Other things related to your focused respiratory assessment, certainly listening to lung sounds, knowing what are normal lung sounds, what are abnormal lung sounds. You know, when you talk about abnormal assessment findings, I can look at a textbook and I can look and say, yeah, this is normal, this is not normal. You then need to kind of think about, okay, it's an abnormal assessment finding. Is it expected in this patient? So for example, those of you who completed the med-surg case this week, the med-surg alternate clinical experience, the asthma Jennifer Hoffman, we know she came in with asthma. I am going to expect to hear wheezes in that patient. So it is still abnormal. Wheezes are abnormal, but I expect to hear them in that particular patient. Now, the next step to that is really to determine, okay, they have wheezes. Is it the same as it was before? Is it getting better or is it getting worse? Okay, that's where you're differentiating and really getting into your assessment, because you're taking that data and it's going to guide the rest of your nursing care. Okay, same thing with pneumonia. If I have a pneumonia patient, I expect for them to have some diminished lung sounds and or some crackles in that area where that pneumonia is. Okay, again, both of those things are abnormal, but they're expected in a patient with pneumonia. You know, so again, we're evaluating as we start treatment, are those abnormal lung sounds getting better? Are they unchanged? Or heaven forbid, are they getting worse and our plan of care is not working and maybe it's something that they need to change the antibiotic or, you know, require a little bit more oxygen and mechanical ventilation, that sort of thing. Also think about cough, okay? And not just asking your patient, you know, do they have a cough? You know, if they're coughing, note what type of cough it is. Is it a dry cough or is it a moist cough? Does it sound wet? Does it sound like there's stuff in there that needs to come up? Is it a weak cough, you know, like a, or is it a strong cough that they're able to bring some stuff up? Is it intermittent? Is it continuous? Is it persistent? If they are bringing stuff up, what does that sputum look like? What is the color? What is the amount? What is the consistency? What is the thickness? Okay, I know it's really gross and every nurse kind of has their vice, and I absolutely hate sputum. I would much rather empty a colostomy than suction a patient. It's just kind of gross. But seriously, that sputum tells you a lot. If it's really thick and tenacious, it's harder for your patient to cough it up versus a sputum that is much more thin, okay, thin in consistency. So you need to kind of look at some stuff like that. As you go through the different Prep U questions, you will see, I think there's at least one or two select all that applies in there that talk about respiratory assessment and have some additional assessments in there. Things like egophony or whispered pectoriloquy. If you go back in your foundations book, they're listed in there. The reality is the nurse generalist who's going to be working in an acute care facility post-graduation, those are advanced assessment techniques that are not part of your standard physical assessment that you're going to do on your hospitalized patient. I did leave those questions in there because I wanted you to be aware of that content, but that is not something that is typically performed as a general shift assessment in an acute care facility. Okay. Let's see. I did mention about looking at these things as a global phenomenon. So again, when we talk about interventions here, these are going to apply to multiple disease processes. So let's start with airway clearance, okay? Because if you think about your nursing diagnoses, you think about your NANDAs, there's 4 big ones that really apply to respiratory patients. And the first one has to do with airway clearance. So if you think about a clear airway, when you breathe the oxygen in, breathe the air in, it's going through your nose, through your mouth, it's being humidified, back to your pharynx, down the trachea, into the bronchi, bronchioles, down to the alveoli. So when we talk about airway clearance, that refers to anything that is obstructing that airway. And that could be something like a foreign body that you aspirated and you're choking on, or it can be things such as inflammation or bronchoconstriction, where those airways are tight. It can also be related to mucus production and sputum, both in the bronchi, the bronchioles, as well as down in the alveoli. So when we talk about airway clearance, the goal is really to clear out that airway so I have a nice open path for that inhaled air to get down into my lungs. So when you think about your basic foundational interventions, turning and repositioning your patient. Well, now wait a minute, that kind of relates to skin. Well, it does. It's very important to help prevent skin breakdown. But that turning and repositioning and getting your patient out of bed to the chair and getting them up to ambulate, all of that helps mobilize respiratory secretions. If your patient is lying there for prolonged periods of time, those secretions that you normally have in your respiratory tract are going to pool and they're going to start accumulating. So when you turn and reposition your patient, not only are you helping their skin, but you're also helping their respiratory status. So that is really, really important. So again, understanding why. So as I turn positions, okay, I'm moving those secretions because they're going to go to a dependent area. So I don't want them staying in the same spot for a long period of time. Now, turning and repositioning by themselves is not going to really help completely fix airway clearance. We kind of tie that together with your coughing and deep breathing, okay? So I want to mobilize those secretions and then get them moving. And then when I cough, I'm hopefully bringing them up so I can expectorate them out and open up that airway. All of us have secretions in our respiratory tract. So all of us, this is why when you first get up in the morning, you might take a couple deep breaths, maybe cough a little bit. Somebody who has a history of asthma, COPD will probably bring up some sputum right then. It's all about opening that airway. But if you have somebody with an underlying condition, you know, such as chronic bronchitis, or they have a pneumonia, you know, or they have like postnasal sinus drip that kind of goes down there that they're coughing up, this is going to be really important to help clear that airway. So the coughing and the deep breathing, very, very important. Chest physiotherapy is also a key treatment modality. Now, again, the chest physiotherapy by itself, the goal is to loosen the mucus in the airway so it makes it easier for the patient to cough it up. So you can do this in many ways. They actually have chest physiotherapy where they actually cup their hands and they're kind of percussing on the patient's chest and back, almost like in a rhythmic drum motion, to help loosen that mucus from the sides of the respiratory tract, get it into the open area so they can then cough it up. They can also use vibration vests. These are very common in patients with cystic fibrosis. So it's actually a vest that they put on and it literally like vibrates and like, you know, and that vibration helps break up that mucus, get it off the sides of the respiratory tract, a little bit looser so the patient can then cough it up. So if you think about these interventions that I've kind of talked about, it makes sense to do your chest physiotherapy or the vest vibration first, and then the coughing and deep breathing, because you want to loosen that mucus first so then they can cough it up. Okay, very important. Now, other things that are going to help get that mucus up, hydrating your patient. Okay, the better hydrated they are, the more liquidy, I should say, those secretions are going to be. They're going to be thinner. As I mentioned before, it's a lot easier to cough up thin secretions than it is thick secretions. So hydration is going to be really important. And in addition to that, if you kind of think about a respiratory patient who's acutely ill, they're likely breathing through their mouth. If they have a fever, they're definitely losing fluid that way. So hydration is going to be really, really important. Suctioning, okay? And although it's not something that we're going to focus too much on in this course, as part of 214, that's actually one of the skills you will do. You will actually check off on it in the lab. But suctioning your patient, if they have copious amounts of secretions in their airway, and especially if they don't have a strong productive cough to be able to bring that stuff up and clear their airway, they may require suctioning to maintain that patency. And if you think about it, there's a reason we have ABCs, airway, breathing, circulation, because I can put oxygen on my patient all day long. I can even, ventilate them with an ambu bag. But if they have secretions or they have aspirated something that is blocking the airway, that oxygen, that ventilation that I'm trying to give isn't going anywhere. It's not getting to the alveoli. So airway clearance is really, really important. You have to address that. Now, to help with airway clearance, there's also some medications. And these were kind of mentioned a little bit in the quiz area. Mucolytics, okay, your Mucomyst, your acetylcysteine, that is going to help. Hold on just 1 minute here. Okay, sorry about that. I got somebody at the door. My daughter's going to get that. So we'll just kind of, go from here. So ignore the little activity in the back. Okay, back to where I was with the, mucolytics is where I was. Sorry about that. So mucolytics, medications for that are going to help loosen that mucus, kind of liquefy that mucus, and be able to cough it out a little bit easier. So that's pretty important. Again, if we're loosening that mucus, making it more liquid, they're able to get it out a little bit faster. Expectorants such as guaifenesin are also really important to do this as well, because these are going to stimulate the cough. They're going to go ahead and stimulate the cough. Again, let's get that mucus out of there. Hold on just 1 minute here.
I didn't know. I was done.
Okay, so the expectorants, they're going to stimulate that cough, and they are especially effective for patients with a productive cough or a moist cough. Even if it's non-productive, if it's moist, this will help stimulate that cough so we can get those secretions and get that mucus out. Okay, so two very important classes of medications, understanding how they work and how that's going to benefit your patient. So that was kind of in relation to airway clearance. Let's go ahead and start focusing a little bit on actual oxygenation and ventilation itself. So I mentioned earlier there's 4 main nursing diagnoses that go along with respiratory disorders. We talked about airway. The next one is going to be ineffective breathing pattern. And when we talk about the breathing pattern, that actually has to do with the ventilation, the actual breathing in, taking the air in down into the lungs, and then exhaling, taking them out. Okay, so when you think about an actual ventilation problem, you think about somebody who is hyperventilating, maybe they're having an anxiety attack, or perhaps they're hypoventilating. Okay, they're taking very either not breathing as enough times per minute, or maybe they're taking very shallow breaths. Kind of associate this a lot with narcotic overdose. Okay, so the problem is actually with the breathing, it's with the ventilation. Depending on what the underlying cause is, we may need to actually ventilate these patients. So using the Ambu bag, using the mechanical ventilation. In some cases, we can use things like CPAP or BiPAP, and in a very rudimentary way, what those things do is they keep the airway from collapsing completely, keep the alveoli from collapsing completely, which makes it easier for your patient to take their next breath. Okay, so those have to do with ventilation. I'm going to kind of then move on to oxygenation or gas exchange, because that's the other diagnosis we tend to think about, impaired gas exchange. So with this, one of your main interventions is going to be supplemental oxygen. Okay, if your patient's pulse ox is down, if they don't have enough oxygen in their circulating blood, we need to provide supplemental oxygen. And all that does is we're providing more oxygen that goes into their airway, that gets down to the alveolar membrane, because we want to maximize the amount of oxygen that gets diffused across there and gets into the blood and delivered to the tissues. So supplemental oxygen is going to be really important. Make sure you review your delivery devices. I think most of us are familiar with the nasal cannula. Obviously goes up through the nose. Make sure the prongs are going up into the nose and not reversed, just for your patient comfort. Do keep in mind that oxygen therapy can dry out the nasal and oral mucous membranes. So it is very important to use humidification, also to do frequent oral care. If the nasal prongs are really bothering your patients, you can use a water-based lubricant, such as like a KY lubricant, to kind of keep that moist in there. It's very important that you don't want to use any type of petroleum-based lubricant, because oxygen can be flammable. Yeah, I can see myself on the screen. Yeah, hi, come on, move. All right, well, the cat's gonna stay there, sorry about that. She is what she is. With the oxygen delivery, the other things to kind of keep in mind with your nasal cannula is to make sure you're looking for skin breakdown, where the nasal cannula is here, behind the ears, anything that might be tight or putting some pressure on your patient's skin. Moving on from nasal cannula, we also look at different type of masks. There's non-rebreather masks. That's kind of our last resort before we get to the point where we're considering BiPAP and intubation. We can use a simple face mask. Those are very helpful if you have a patient who's a mouth breather or they really cannot tolerate the nasal cannula. Now, that being said, that mask can sometimes be very constricting and make it difficult for patients. And also it's going to interfere with eating. So if they're using a simple face mask during times of eating, they are gonna have to switch to a nasal cannula. The other mask I really wanted to focus on was the Venturi mask. And we talked about the question on the quiz related to oxygen toxicity in COPD patients. We have to be very careful with oxygen therapy with that particular set of patients, just simply because if they get too much oxygen, it will actually depress their drive to breathe, and they can actually stop breathing on us. So that's a major issue. With a Venturi mask, because there are different adapters, it is much more precise. You can be very specific in the amount of supplemental oxygen that they're getting. So if we can't maintain or care for a patient with COPD on the nasal cannula, our next best choice is going to be to go to that Venturi mask, just because it is so specific with the adapters, because we want to give them enough to make sure they're not completely hypoxic, but not too much that we put them into toxicity. So that's a really key point with that. Other things that assist with oxygenation, positioning of your patient, okay? Sitting them upright is gonna allow for more room for the lungs to expand, okay? So again, it doesn't matter if it's my asthma patient, my pneumonia patient, my COPD, cystic fibrosis, whatever, okay? They are all gonna benefit from an upright positioning, just helping them breathe, allowing for that lung expansion. Incentive spirometry, again, helps with the patient taking deep breaths. The whole idea when you're using the IS is for the patient to take a slow, deep breath in, and it's all about expanding the alveoli, okay? Expanding that alveoli, getting them open. Because when you're opening up those alveoli, those secretions have more difficulty pooling there, causing a problem. This is why we use incentive spirometry in our post-op patients, because we don't want them developing atelectasis that can then turn into pneumonia. Certainly smoking cessation is going to be a critical aspect of caring for respiratory patients. Obviously, in a perfect world, no smoking would be great. But if you're talking a patient who's been smoking 2 packs a day, it's very difficult for them to quit cold turkey on their own. Now, when they're in the hospital, that is a great time to get them through that first initial part of nicotine withdrawal. So they will use things such as nicotine patches, your Nicoderm patches, nicotine gum, to kind of help with those cravings. If your patient's a smoker and they're in with a respiratory issue and one of those options has not been prescribed for them, this is where you can advocate for your patient and really collaborate with the provider and say, look, we need to get an order for this. Sometimes it's part of the standard protocol. Other times, it's offered to the patient and the patient refuses. It is what it is. Ultimately, the patient has the right to refuse it, but it is appropriate for us to be offering that to try to help them through that initial withdrawal, essentially, from the nicotine, because it really is. Other things that we can do as we're promoting and supporting them in that smoking cessation journey is helping them develop more positive coping habits. It's hard to quit smoking if the person that they live with or individuals they live with also smoke. Or if in the occupation that they have, they're around people who are smoking all the time. So anything we can do to kind of support that transition is really important. And not only RNs educating the patient, but also the respiratory therapists. Anybody can help reinforce that, certainly the provider. Another intervention, foundational, that's really important for your respiratory patients is balancing activity and rest. In foundations, we always talk to you about therapeutic communication. And we're like, well, tell me more. You don't want to ask closed-ended questions. If your patient is huffing and puffing and really working hard to breathe, that is not the time to say, tell me how you're feeling today, or tell me about that. Those patients are lucky if they can answer yes or no questions without becoming extremely short of breath, or maybe they already are extremely short of breath and they can't even answer that. It's a nod or a shake of their head. So, we talk about principles of the NCLEX and we talk about principles of therapeutic communication and care, but this is where we talk about individualizing your care to the specific patient. And for these patients, it is appropriate to use closed-end communication. It is also appropriate to assist them with their ADLs as much as they need. Now, that's a total flip side from, what we're saying. We want to promote independence and we want to encourage them to do as much on their own. That is true. And that is a great underlying principle. But that doesn't take priority over supporting a patient's oxygenation. If they are so winded at rest or even with activity that they cannot do that, we need to provide that support. So it's really balancing that activity and rest. I've seen this with patients. There were times where we couldn't even complete a whole bath because the patient becomes so short of breath. Or there's times where the patient truly requires complete and total care. They can barely even use the washcloth to wash their own face, and they require nursing support to do everything else. So balancing activity and rest is going to be critical. Now, as the patient recovers, if they're in here with a COPD exacerbation or a pneumonia, our goal is to get them back to their baseline, okay? So that's where we're going to kind of make our focus. But again, initially, we may need to support that because their oxygenation, they just don't have the capacity oxygenation-wise to support their body functioning, okay? Other things that help with that, and I want to mention this, it's kind of in a roundabout way, is their diet. When you have somebody who's ill, their body is using more energy. So they're going to require more calories, more nutrients, more protein to begin with. But the other thing you need to think about for somebody that is actively working to breathe, very short of breath. So they're using energy to actively breathe. We also use energy when we eat, chewing up the food, swallowing the food. And these patients, and I'm thinking in particular your end stage COPD patients, they are severe COPD, they've had COPD for a long time. And what really happens towards the end is they get very cachectic because they lose weight simply because they just cannot take in the amount of nutrients and calories to support what their body is expending through breathing and through eating. So diet's going to be really, really important for these patients. You want high nutritional foods, high calorie, high protein, and you want things that are soft, easy to chew. For your end stagers, liquid things that are packed with nutrients are much better than even soft foods. Because even with soft, they are still expending some energy in chewing that. But something that's liquid that they're not really having to chew, that they're able to swallow, that's going to be the best bet for them. It's really, when you see somebody who is end stage COPD and they've been there for quite a while, we took care of a lady down at Jersey Shore, probably for on and off for about 5 years, different clinical groups that I had down there. She has since passed, but the very last time she was there that we were taking care of her, I mean, her arms were so skinny. They look like a toddler's arm. She honestly, you know, I think she was like 5'5", and she reminded me of someone in a concentration camp. That's how malnourished and cachectic she was. So nutrition really is a huge piece of this. Talking to dietary, consulting dietary, liquid supplements, you know, the Boost Plus, different things like that to really support their nutrition throughout this disease process. In relation to medications to help promote oxygenation, I want to talk a little bit about the bronchodilators. When you think about bronchodilators, just some basic things to remember is you have short-acting and you have long-acting bronchodilators. Your long-acting are considered maintenance medications. So those should be taken every day without fail, as prescribed, no matter what, because that's all about, you know, maintaining their underlying function. Short-acting bronchodilators are also sometimes used as maintenance therapy to help manage their symptoms throughout the day. But where we see them used even more frequently will be with exacerbations or acute problems. You know, if somebody has an acute asthma attack, if they have an acute exacerbation of COPD, and certainly if they're underlying healthy and now they have a pneumonia going on, we're going to use those bronchodilators. Again, we want to open up the airways. A larger opening is going to allow for easier airflow from the, you know, nose, mouth, all the way down to the alveoli. The more air I can get down there, the more oxygen I get down there, the more I'm going to have, you know, diffuse over the alveolar capillary membrane to provide that oxygenation. The other class of medications, and I kind of mentioned them a little bit before when we went over the exam, was your glucocorticoids. So it's very important when we think about your steroids, and that's generally how they're referred to as the steroids. Steroids are used in many different forms. Now, inhaled steroids, either through a dry powder inhaler or through a meter dose inhaler or even through a nebulizer, those are really aimed at long-term control. Okay, so if you have a patient who takes a combination med, maybe Advair, they have fluticasone and salmeterol in there. The salmeterol is the long-acting bronchodilator. Your fluticasone is the inhaled corticosteroid. And these are all aimed at reducing inflammation in the airways. Again, these are maintenance therapy. Then you'll have patients who have an exacerbation. So they're having maybe an acute exacerbation of asthma or an acute exacerbation of COPD. And now we're using IV steroids, something like methylprednisolone, or PO steroids like your prednisone. These are short-term steroids that we use to acutely reduce the inflammation to kind of get them over the hump. It is those steroids that tend to cause the most problem with your hyperglycemia. So you can have a patient who's a controlled diabetic and they will be put on prednisone or methylprednisolone, and their sugars will shoot up in the 200s and 300s. And it's very important that you educate those patients, because that can be really devastating for someone that has controlled diabetes, that really works hard to control their blood sugars. And they think it's something that they did, and it's not, it's their medication. On the flip side, you can also have a patient who is not a diabetic at all, is on one of these medications, shoots their sugar up, and because of this anticipated side effect, the provider schedules, they order AccuChecks or blood sugar checks with sliding scale insulin. Okay, well, the first time you go in to check this patient's blood sugar, she's gonna think you're crazy because she's not diabetic and she doesn't need to check her blood sugar. And what are you doing? You need to be able to understand this and be able to explain it to the patient, that this is because of a side effect of these steroids to treat this condition. That's why the sugar is up. That's why we're testing the sugar. And that's why, depending on what the number is, you may be getting some insulin. That does not mean they are going home on insulin. So that's a huge patient teaching point that you need to understand, because the patient's looking at you, they're looking at you, the RN, to provide that education and to provide that guidance. And teaching is part of our RN role. Okay. So that was the big points that I wanted to cover. I'm going to answer questions here on the side, and then I'm going to briefly go into a review of ABGs, because as I was talking to students yesterday via Zoom and email, that seemed to be a common thread, that people were concerned about ABGs. So I want to do a brief review of that. But before I get there, I have lots and lots of messages over here on the side. So let me just start at the top, and I'm going to work my way down, answer those questions, and then we'll get into the ABGs. So what damage does long-term asthma cause? Great question. So with asthma, it is considered a reversible airway obstruction. But if you think about what happens with asthma, when they're having an acute attack, it's a hypersensitivity response. So you have the bronchoconstriction, you have the stimulation of the inflammatory process. When that happens over and over and over again, it does cause some progressive damage to the airways. So for somebody with asthma, controlling that asthma is going to be really important. We don't want those flare-ups, because each one does cause a level of progressive damage. So if you have somebody who is asthmatic for many, many years, they will likely progress into COPD, okay, into, your chronic obstructive pulmonary disease. So asthma is kind of that, it has its foot in each side. It's reversible acutely, but long-term it does cause some damage. So I answer the next question, can asthma cause or be a risk factor for COPD? Yes, it absolutely can. Let's see here. Will you hear wheezes with chronic bronchitis? You might. So with chronic bronchitis, it is actually a combination of two problems. So you do have a narrowed airway, and the narrowed airway is a little bit from bronchoconstriction, but a lot of it is also from a hypersecretion of mucus from the inner lining of the respiratory tract. And that's why your chronic bronchitis patients have that persistent productive cough. So you have two problems here. I have airway narrowing because of the bronchoconstriction, and I also have this excessive mucus. So with your chronic bronchitis, you may hear some wheezes with that, but you're more likely to hear rhonchi and noisy respirations because of that mucus and those secretions in the airway. Okay, in acute pharyngitis, I thought it was typically recommended to drink hot tea for a sore throat. I thought that relieved discomfort. It really depends. So we're kind of looking at the lesser of two evils here. So when you put heat on something that's inflamed, sometimes that can stimulate the inflammatory process and make things work. On the flip side, when we apply heat, or when we think about your breathing in the steam, that helps open up the airways, at least the upper airways, so you can get a little bit more airflow in there. So when we talk about acute pharyngitis, it hurts when they're swallowing. They tend to have that sore throat, that irritation there. Sometimes that can be exacerbated by hot things or really, really cold things. So it's really going to depend on patient comfort. With the acute pharyngitis, the important thing is to figure out with the culture, is this a bacterial issue? Is this a viral issue? Because if it's bacterial, if it's like acute streptococcus, we need to make sure we're treating that, because long-term untreated, well, not long-term, but untreated strep can actually lead to cardiac issues. It can lead to kidney issues. So that's pretty important that we identify and treat strep fairly early. Why would you want to apply heat to the nose with rhinosinusitis? Does it increase the inflammatory process? Why would you not need to take a nasal decongestant? So great questions there. So kind of the same stuff that I was talking about a little bit. By applying the heat, you're causing vasodilation. So the idea is any excess fluid in there should get back into the circulation and then be able to be excreted. But the other thing is just trying to open up those airways. With regards to a nasal decongestant, they tend to be very helpful, but remember that you should only be using those for about 3 to 4 days. And you shouldn't be using them longer than that, because they can actually cause what we call rebound congestion. So they'll get better with using that, and then all of a sudden they keep using it and that congestion comes back. So again, medications are helpful for symptom management, but also look at those non-pharmacological things to try to help open up those upper airways. Okay, why would obstructive sleep apnea cause a patient to have polycythemia? Okay, this is a great question. So first of all, polycythemia is an increased production of red blood cells. So if you think back to Unit 3, when we talked about red blood cells, the red blood cells contain the hemoglobin, and the hemoglobin is what carries the oxygen. So with obstructive sleep apnea, and actually this is true with COPD, with patients who have been COPD for a long time, they've had it. So their body recognizes these low levels of oxygen. So as a compensatory mechanism to try to kind of make up for it, the body will actually try to increase production of red blood cells. And the idea is the more red blood cells I have, the more oxygen that I can carry. And that is critical for a patient with COPD or obstructive sleep apnea. Now, what I just described also, is contingent upon your patient having healthy kidneys. So if they already have chronic kidney disease, you're not necessarily going to see that increase in red blood cell count the way we would expect in somebody with healthy kidneys. Okay. How do you differentiate between fully and partially compensated? I'm going to have you hold that question for when I get to the ABG review. I will address that then. Why would asthma create a productive cough? I thought this was a dry cough. It actually could go either way. Most of the time with asthma, it's going to be a dry cough. Usually an asthma attack is brought on by some sort of irritant that causes like a hypersensitivity reaction. As part of that hypersensitivity reaction though, some people can start secreting mucus, and the white blood cells that go there as part of the inflammatory and immune response can create exudate. So you can potentially have a productive cough with that. Most of the asthma patients that I've had that it's been truly just a straight asthma exacerbation, those are typically a dry cough. Why should chest physiotherapy be performed before bedtime? Great question. So before bedtime, think about when you're sleeping at night. How long are you going to lay there? Okay, hopefully a couple of hours. Hopefully y'all are getting adequate sleep. But they're going to be laying in a position, or they might change positions in the bed, but it's not going to be a whole lot. So you have more pooling of secretions. So it's very, very important to do chest physiotherapy before bed, because we want to make the airways as clear as possible before they're lying there for that prolonged period of time. So when you think about doing chest physiotherapy, sorry, I just got to reposition here. When you think about doing chest physiotherapy, you definitely want to do it before bed. Other times throughout the day, if the patient's getting it multiple times a day, you want to do it at least like an hour to an hour and a half before meals, because you want to, again, open up that airway so they have a nice patent airway for when they're using energy to eat. And also, if you do it after they eat, you're more likely to make them throw up, and then you risk the, the chance of aspiration. Why would you collect a sputum culture from a patient with acute airway exacerbation from CF before a breathing treatment? Airway first. With this, with your CF, now remember, CF is a very different disease process than the others. It is still an oxygenation problem, but part of CF is their body just produces this very thick, viscous mucus. So the first thing you want to do is actually, you want to suction their airway. You want to get that cough out. If they can cough something up for you, great. Otherwise, you want to suction. And with suctioning, you can actually collect a sputum sample that way. Again, it kind of goes back to the basics. I'm going to give them a breathing treatment, but if their airway is clogged with that mucus, the air that they breathe in, the medication they breathe in is not getting all the way down there. So for a CF patient, because it's very specific to that diagnosis, the type of secretions that they have, we want to go ahead and get the sample. But by doing that and getting the sample, we're also clearing the airway to provide a mechanism for that medication to get down there. Okay. What are interventions to treat oxygen toxicity? Well, the first thing is going to be to not use so much oxygen on the patient. You kind of need to do that. Really, it's going to be supporting. What happens with oxygen toxicity, once we identify it and we turn the oxygen down, it will start to fix itself. But if you go all the way, like if this patient literally with oxygen toxicity, they stop breathing on you, we are going to have to ventilate for them, whether it's with an ambu bag, or they're on mechanical ventilation with a low oxygen concentration, but we're actually breathing and we're ventilating for them. With patients with respiratory diseases like asthma and COPD, be started on a rescue med first and then go to long-term depending if they have frequent exacerbations. Great question. So they actually, when you have somebody with a chronic respiratory disease, such as asthma or COPD, their treatment regimen is going to likely include both. Okay, so depending on how they present, most people are not just diagnosed with asthma or COPD without having some sort of exacerbation initially. That's what caused them to seek treatment. That's what kind of sets the whole thing off. So initially with the exacerbation, we're going to use those short-acting treatments because we need to open up those airways. We need to maximize oxygenation. As we're doing that, we are going to go ahead and get them started right away on your long-term and your maintenance therapy. It is very important to educate these patients that their long-term meds will not take care of their short-term, their acute symptoms. Okay, something like your fluticasone, your salmeterol. If I'm having an active asthma exacerbation right now and I can't breathe, my Advair is not going to help me. Okay, my Singulair is not going to help me. I need something very short-acting. I need my rescue inhaler. I need my albuterol. But when we first see these patients, a lot of times it's related to an exacerbation, so we start treating that, but we start them on that long-term maintenance medication. And what we do for long-term management, they'll be on that maintenance medication, but they will also have that rescue med that they'll take if they start having acute shortness of breath symptoms. Okay. Just scrolling on down here. Good questions. Okay, what are the signs and symptoms of acute pharyngitis? Okay, so acute pharyngitis, you're going to have, the painful and the difficult swallowing. If I look in the pharynx area, it tends to be red, it tends to be inflamed. There might be some exudate sitting back there, like on the tonsil area. So those are typically what you're going to see. Your patient might report difficulty swallowing or painful swallowing. And that could be a comfort thing, but that can also cause an issue with increasing their risk of aspiration if they're eating or drinking, or also increase their risk of dehydration because maybe they're not eating and drinking because it hurts so much. What is the best O2 therapy for a patient with pneumonia? Well, it kind of depends. We only ever want to use enough oxygen to achieve our goal. Okay, so if I can keep my patient's saturation where I need to with 2 liters of nasal cannula, then that's where I want to stay. Okay, I will work my way up as needed, but I want to always treat them with the lowest amount of oxygen needed to get the job done. You know, it's kind of that same concept with pain medication. You know, okay, well, they're ordered 5 milligrams of oxycodone or 10 milligrams of oxycodone. Why wouldn't I just give them 10? Well, if they have a pain level of 4 and I can manage that with the 5 milligrams, there's no need for me to give the 10 milligrams. So we're always looking at just giving what we need to get the job done, because you need to keep in mind every intervention that we do, or every medication that we do, it's the benefit versus the risk to the patient. So we want to use the lowest amount possible to get the job done. Okay, what are the diagnostic lab signs and symptoms of CF? Okay, so cystic fibrosis, you'll talk more about cystic fibrosis as a pediatric disease because it is genetic. We do see it really affecting kids. In fact, it's only really been in the last 20 years or so that they started including cystic fibrosis in the adult med-surg nursing textbooks, because the reality is prior to that, the kids didn't make it to adulthood. But just for now, what I want you to understand is it's a genetic disorder. It is going to cause the increased amounts of that thick viscous mucus in the respiratory tract. It's also in the GI tract, so it affects their absorption of nutrients, so they tend to be underweight, malnourished as well. But from a respiratory standpoint, it affects their airway clearance because they have all this thick viscous mucus in there that makes it difficult to even ventilate, let alone gas exchange down in the alveoli. How does long-term control of inhaled corticosteroids relate to COPD? Okay, so great question. So when we use inhaled corticosteroids with our COPD patients, those steroids reduce the inflammation in the inner lining of the bronchi and the bronchioles. Okay, so if I'm reducing the inflammation, by reducing the inflammation, I'm actually opening the airway a little bit. Okay, when you think about bronchodilators, they're actually working on the muscles and the outside layers of your bronchi and your bronchioles. The corticosteroids are about reducing the inflammation on the inner lining. So long-term with our inhaled steroids, we want to keep that edema, that swelling down. And then if they're having a flare-up where they have like an acute inflammation and acute flare-up of that swelling, that's when we would use the IV methylprednisolone or the PO prednisone. Let's see. Okay, if a patient comes in with acute exacerbation related to COPD, would the priority assessment be the same or different if a patient had a history of asthma and no COPD? Okay, so when you talk about your priority, it really doesn't matter what diagnosis we're talking about. I don't care if they have asthma. I don't care if they have COPD, if they have pneumonia. If they can't breathe, okay, and they're not getting adequate oxygenation, or they have copious amounts of secretions that they can't clear their airway, those things are priority, regardless of what the underlying diagnosis is. Now, part of your plan of care is going to involve treating the underlying diagnosis, but at that moment, it doesn't matter why they're having a problem with airway clearance. We just need to clear the airway. It doesn't matter why they're having a problem with oxygenation. We need to get oxygen into them now. Okay, let me see here. What is the most accurate when assessing airway obstruction, PFTs or spirometry? So there's two different things, and your question talks about acute airway obstruction. So if you're looking at something acute, you know, we can use spirometry. For our asthmas, we can look at our peak flows. When you think about true pulmonary function tests, they are for truly diagnosing COPD and really tracking the progression of COPD. Also, pulmonary function tests are much more involved and require a lot of different pieces than just the spirometry. So it is easier to do the spirometry. Spirometry, we can, you know, we kind of do that regardless. PFTs are typically done as an outpatient. They're also done when the patient is relatively stable. You would not do PFTs on a patient who was just hospitalized with acute COPD exacerbation, because of course the results are going to be down. They're having an acute exacerbation. PFTs are helpful in providing the true diagnostic criteria for COPD and then tracking to see how that COPD is progressing. Are they considered mild COPD, moderate? Are they severe, end stage? Can you post practice ABG questions? Yes, I will, and hold that thought because we're going to get to that here in just a minute. Should they be coughing periodically during chest physiotherapy? They can. It really depends on how they're doing it. The cough is going to be most effective once we've loosened up the mucus. But yeah, if you're doing chest physiotherapy and your patient's like, I got to cough, by all means, stop and let them hack that thing out, because there's something in there that's stimulating them to cough, and we want it out. We want that airway clear. Okay, so expectorants are not used on patients with dry, non-productive coughs. Typically, if it's truly a dry cough and it's non-productive, they're not going to use expectorants. Now, if it's a moist, non-productive cough, like there's stuff in there, but your patient just can't cough it up, then we absolutely will use expectorants, because we want to get that mucus out. Not only to ideally get a sample and see what it looks like, but really just to clear their airway. How many liters of O2 requires humidification? If we're only giving 1 to 2 liters for a short period of time, it does not seem reasonable to use humidification. Great question. So the rule of thumb is if you're at 4 liters or more, you must use humidification. Under 4 liters, it's really up to the discretion of the nurse. And here's what I'm going to tell you. If the environment is very dry, which a lot of hospital environments are, it may be beneficial to use humidification. If your patient is reporting irritated mucous membranes of the nose or drying of the nose there, it's absolutely appropriate to use humidification. You know, the hard fast rule is if it's 4 or above, you have to use humidification. Below that, it's going to be based on nursing judgment, nursing discretion. Okay. What conditions would you need more precise oxygen therapy with a Venturi mask? Great question. The one that I use the Venturi mask the most with was typically your COPD patients with a severe exacerbation. Because again, it allows you to be able to use the different adapters to provide a specific percentage amount of oxygen. That's pretty much been my experience. I mean, we can use it for other patients who are having difficulty with breathing and oxygenation. But the Venturi mask is very helpful because, again, it's very specific, it's very precise. Okay, PrepU had a question that referred to a COPD patient, and the correct answer was to increase the distance that they could walk after an exacerbation, not return them to their previous level of ability. I don't have the question in front of me, so I don't know the exact wording. But if I'm dealing with a patient with a COPD exacerbation, yes, we're going to do this in stages. My long-term goal is to get them back to their baseline functioning. The reality is, with today's healthcare environment and today's insurances, they're likely, if that COPD exacerbation patient stays 3 or 4 days, we're lucky. Okay, so my goal for them is, in that short period of time, is to increase the amount of activity that they can do. We just keep kind of building that up. Long term, we do want to get them back to their baseline, and this is why many of these patients will do what we call pulmonary rehab after their hospital stay. So it's very similar to like cardiac rehab after a patient has a heart attack, but pulmonary rehab, they go, they're doing exercises, they're working with different things, and the goal is to build up their endurance, that they're able to do more, with the ultimate goal of getting them back to their baseline. Okay, Venturi is good for COPD. You can give a lot of airflow. Oh, okay, that's not a question, that's just a comment. Okay, so, okay, I'll ignore that. What is the risk of death with a PE? It escalates quickly, right? Yeah, so we're in the capture, I talked a little bit about PE, and I'm going to hit it again when we get into the Unit 5 Class 4 capture, because we talk about DVT, and those two things go together. Once we're talking about a PE, that clot is now up in the pulmonary vasculature. So the issue with that is when that clot lodges in there, not only is blood flow not getting into that area, so it's not being oxygenated before continuing to circulate, but that area of the lung is not getting adequate oxygenation to feed those tissues, okay, to actually feed the process of ventilation and perfusion and diffusion. Okay, so PE, huge risk of death. Whether it's going to kill your patient or not, it really depends on a lot of things. How large is the clot? Where is the clot lodged? Are we talking a main pulmonary artery? Because then your patient is circling the drain pretty fast. Are we talking a very tiny clot that's broken off and got lodged up in like the periphery and it's affecting a smaller part of the lung? Then your patient's probably going to be okay. It really honestly depends on the size of the clot, and it depends on the location of the clot. Okay. Oh, appropriate goal for a COPD patient, and the answer was to increase walking distance around a city block without shortness of breath. Okay, and that kind of speaks to the same thing. You know, we do want them to progressively be able to increase their activity. So again, I don't have the question in front of me, so I don't know what the exact wording was. But if the concept was trying to get them to increase their distance, that makes sense. Ultimately, our goal would be to get them back to baseline, which is really the goal for any type of chronic condition, whether we're talking about, you know, a COPD patient or we're talking about a post-stroke patient where we're rehabbing them. Our goal is to kind of get them back to maximum function, ideally back to their baseline. Now, as COPD progresses, you know, getting them back to their true baseline is going to become, you know, less and less realistic. So we're just trying to maximize the activity that they're able to do. Okay, I think that's all the questions. I am going to attempt to share my screen here. So, you know, we're going to see how this goes. Okay, share screen, acid base, share. Okay, hold on a minute here. Oh, I don't know how to put this into slideshow mode. Oh, wait, I got it. I got it. We're here. There we go. Okay. All right, so everyone should be able to see my screen right now. This is just an acid-base balance review and just kind of a brief review of ABG interpretation. I just want to hit some of the main concepts. I am going to be putting up an ABG worksheet that has values on there for you guys to interpret. And we're going to be going a little bit beyond just what disorder is this. We're going to start looking at compensation. So that's kind of what I wanted to review today. Okay. All right, so when we talk about acid-base balance, just a very brief review, you know, your acid is a substance that contains your hydrogen ions. Your base is something that traps hydrogen ions. And the whole idea is for this to balance out, okay? For it to be, you know, a nice balanced scale. Your body likes the concept of homeostasis. It's like Goldilocks and the three bears. I don't want it too low. I don't want it too high. I want it just right, okay? So your body produces acids continuously. It's just part of your natural metabolism. And there's a lot of different systems in your body that kind of keep that balance, okay? Two of the big ones that we're talking about are your lungs and your kidneys. All right, so when we think about balance and we talk about pH, now if you go back to your chemistry and you know, that goes on a scale from 1 to 14 and the magic number is 7 in between, okay? Let's kind of throw that out the window. So when you look at normal arterial pH, based on the human blood, the human arterial blood, our normal values are 7.35 to 7.45. That is something you just have to know. There are values and labs that you just need to know. That's a memorization thing, okay? But you can see on the graph on the screen that normal, that 7.35 to 7.45, when I get outside of that, if I'm on the lower end, I'm tipping acidotic, and eventually if I get too low, it's not compatible with life. On the flip side, if I'm tipping to the high side, I'm getting alkalotic. Again, if I get too alkalotic, it's not compatible with life. So it's very important that that pH be balanced. So when we talk about how this all works in your patient, your lungs and your kidneys are going to work to balance this out, okay? And that's where you'll get the other two readings, your PCO2 and your bicarb. Okay, so buffers, I'm not worried about that. Let's talk specifically about your lungs. So your lungs will control how much CO2 they keep in the body or how much they get rid of, eliminate from the body, based on how fast you breathe, based on the respiratory rate, but also based on the respiratory depth. Okay, so your normal range for your PCO2 is 35 to 45. Again, you just need to know that. But I just want you to kind of conceptually sit back and think for a minute. If I have too much acid in my body, okay, and CO2 is an acid. If I have too much acid in my body, my lungs want to get rid of that acid. So if you think when you breathe in, I'm breathing in oxygen. When I breathe out, I'm breathing out CO2. So if I have too much CO2 in my body, my lungs want to get rid of it. They're going to do it by increasing the respiratory rate and increasing the respiratory depth to try to push out, to blow out that CO2. Okay, that concept is called compensation. Okay, now on the flip side, we also have the kidneys. So they help balance all this out by deciding what they're going to excrete in the urine. Are they going to hold on to hydrogen? Are they going to hold on to bicarbonate? Or are they going to put it out in the urine for you to be able to excrete? Okay, so that's the two ways that your body is balancing this out. So a normal range of bicarb is 22 to 26 milliequivalents per liter. Again, those are numbers you just absolutely have to know. Those are things that if you don't know, you definitely want to learn and brain dump on your blank piece of paper during the exam. Okay, so all of that we were talking about was balancing it out. So when you have something that's off, when the pH is off, when it's not within the normal limits, it's either going to be acidotic or alkalotic, okay, based on which way the pH is going, okay, but then it's going to be classified as either respiratory or metabolic, and that's going to be based by the cause of the disorder. You know, what is the issue that's causing the problem? So if the lungs are the problem, it's considered a respiratory thing, whether it's respiratory acidosis or respiratory alkalosis, okay? If the lungs are fine, there's nothing wrong with the lungs aren't causing the problem, it's a problem with the kidneys or it's a problem with the patient's metabolic state, then it's considered a metabolic acidosis or alkalosis, okay? So if you just kind of think about, you know, this unit focuses on respiratory, so we're going to be focusing mostly on respiratory. Now the worksheet that I will be posting for you has metabolic in there too, because it's actually from Foundations. It actually goes into fluid and electrolyte balance as well. But for this unit, we're primarily focusing on respiratory.
Are you going to have this PowerPoint posted?
I am. I absolutely will, along with a freebie Friday sheet and the practice worksheet.
Okay, thank you.
Sounds good. All right, so when you look at the disorder, it's going to be alkalotic or acidotic, and it's going to be respiratory or metabolic. Okay, so that I think is what you likely did in Foundations, looking at the numbers and figuring out, is this a respiratory acidosis? Is it a respiratory alkalosis? Is it a metabolic acidosis? Okay. Now we're going to the next level. We're talking about compensation. As I mentioned before, your healthy body is going to try to correct this acid-base imbalance because it doesn't like to be outside of that normal range. It wants to kind of fix it so I get back in that normal range. So the process of trying to fix it is what's called compensation. So I mentioned before, the lungs are going to either excrete or retain CO2 as needed. So let's stop for a minute and go back to Unit 4. You're like, oh my God, it's Unit 4. Okay, diabetic ketoacidosis. Okay, diabetic ketoacidosis. Well, it's acidosis, so you already know it's an acidosis. But is it a respiratory problem or a metabolic problem? It's a metabolic problem. There's nothing wrong with the lungs here. It's a metabolic problem. So somebody with DKA has a metabolic acidosis. Okay, there's too much acid in the body. So the lungs are going to try to get rid of some of that CO2. Okay, well, it's going to do that by increasing the respiratory rate and increasing the depth of respiration. So those fast, deep respirations, Kussmaul's respirations that we always see associated with DKA, it's because of the compensation of the underlying acid-base problem. The Kussmaul's respirations is that process of compensation, okay? So for us, because we're in the respiratory unit, we're dealing with respiratory acidosis, we're dealing with respiratory alkalosis. So the problem is the lungs or ventilation. So it would be the kidneys that would be the compensating factor. The thing to remember with the kidneys is they work well to compensate, but it takes them a while to get going. So somebody that has a very acute problem, it's likely going to be uncompensated, especially at first, because the kidneys take a while to get going. So for example, you're out walking on the street and you find somebody who's not breathing. Okay, let's say it's a drug overdose, it's a narcotic overdose. So they're not breathing, they're not ventilating, they're not getting oxygen across the alveolar capillary membrane. It's a very acute problem. If we don't address the ventilation, if we don't address the oxygenation now, they are going to die, okay? They're going to be dead far before the kidneys even have time to even think about compensating. Usually it takes at least 24 hours for the kidneys, for you to start seeing some compensation with the kidneys. So with an acute issue, respiratory wise, you're not going to see that compensation. If it's a metabolic problem and it's the kidneys, if it's the metabolic problem and it's the lungs that are compensating, that happens very quickly in healthy lungs. So again, you have to know your normal ranges in order to interpret your ABGs. So these numbers have to be committed to your memory. No ifs, ands, or buts. And from there, once you know that, there are 5 basic steps just to look at how to interpret an ABG. So you start with the pH value. Is it acidic or alkalytic? Okay, which one is it? If your pH is normal, okay, it's within that normal limits, but you look down at your PCO2 and you look down at your bicarb and one of those is not normal, there is a problem, okay? It's not a normal ABG. So if you're looking at the pH and it is normal, okay, 7.35 to 7.45. The magic midpoint is 7.4. So if it's within normal limits, which side is it leaning to? Is it leaning towards the acidotic side? Is it leaning towards the alkalytic side? Okay, so that's what you want to look at if it's normal. Is it acidic or is it alkalytic leaning towards? After you determine that, because that's going to tell you, is it acidosis or is it alkalosis? Then you look at your PCO2 level. If it's high, it means it's acidic, because if you think about it, your normal value is 35 to 45, and your PCO2 is your acid indicator. So the higher the number, the more acid your patient has in the body. So if it's high, it's acidic. If it's low, it's alkalytic. Then I want to look at the bicarb level. Again, bicarb, that's my base indicator. So if it's high, they're going to be alkalytic. If it's low, they're acidotic. So when you look at those 3 numbers and you interpret them, and I would encourage you to write the word next to it. So look at the pH, determine, is it acid or is it alk? Look at the PCO2, is it acid or is it alk? Same thing with the bicarb, is it acid or is it alk? And then you're going to play the game. One of these things just doesn't belong here. So the ones that are matching. So if the pH says it's acidotic, and you look and see which one, the PCO2 or the bicarb, is going in the same direction, which one of those is acidotic, that's what's going to tell you if it's respiratory or metabolic, okay? If it's the bicarb that's going in the same direction, it's a metabolic problem. If it's the PCO2 that's going in the same direction as the pH, it's a respiratory problem, okay? So that's your basic interpretation. Then to start looking at compensation. Okay, so just kind of think about this conceptually for a moment. Let's say it's respiratory acidosis, okay? Respiratory acidosis, the problem is the lungs. We know the kidneys are going to be the ones that are doing the compensation, okay? But it takes the kidneys a little bit of time to get going. So if they're acidotic, if all this is acidotic, my kidneys are going to try to get rid of acid through the urine, and they're going to hold on to bicarbonate in the body to try to balance it out. So by holding on to the bicarbonate, you're going to see the bicarb level, the HCO3 level, start moving more in the opposite direction. Okay, so when you see a set of lab values, okay, and you have your pH is abnormal, and either the PCO2 or the HCO3 is abnormal, that kind of tells you what direction it's going in, but the other indicator is normal, that is uncompensated. When you start seeing the opposite indicator moving in the other direction to try to balance it out, that's compensation. You know your body is starting to compensate. Now, how do you determine if it's full compensation versus partial compensation? I go back and ask you, what's the ultimate goal? What is your body trying to do? It's trying to get the pH back within its normal limits. So if your pH is back within that normal limits, it's full compensation. If your pH is not quite there, but you have that opposite indicator moving in the other direction to try to balance it out, that's partial compensation. Okay, so remember, your body, if it's given the opportunity, it's going to try to compensate. It likes homeostasis. It wants to be controlled. It wants to be happy. Okay, the key with us, since we're dealing with respiratory problems, is we need to keep that patient alive long enough for those kidneys to start compensating. So what you will see, just to kind of put this all into perspective, in a stable COPD patient, they are chronically in a compensated compensated respiratory acidosis. Okay, they are constantly in a respiratory acidosis. The idea is for the body to fully compensate, keep that pH value within normal limits. But if you look at their PCO2 and you look at their bicarb, they're always going to be out of whack. They're always going to be in a respiratory acidosis. In stable, that should be a compensated respiratory acidosis. Now, in an exacerbation, okay, in an exacerbation, that compensation, it's not going to be enough because they're going to have more acid in their body. So at that point, it becomes uncompensated or partially compensated. Okay, so as you look at this material and you work through those practice questions, you know, I really want you kind of thinking about that as you're working through interpreting them, and what type of patient would you see. The bottom line is, if they are holding on to the acid, okay, we're going to have to try to support their oxygenation so they can blow off that CO2. Now, if you think about your COPD patient, okay, and the disease process with COPD, they already have trouble exhaling the CO2, okay? That's why they're in that chronic respiratory acidosis, okay? So it's all about supporting them and supporting their body to try to get those ABGs back within normal limits. So that's why it's so important to treat those exacerbations and to treat them very quickly. So when you think about a COPD exacerbation, not all the time, but a lot of times the underlying cause is an infection, either an acute bronchitis, maybe it's a pneumonia, maybe it's an influenza, maybe it's COVID-19, okay? So it's very, very important that we treat them for that potential cause. And because a lot of times it is an infection, when you see somebody with COPD come into the acute care unit, okay, and they are requiring additional oxygen to maintain that, they're requiring additional ventilatory support, we're not going to wait to start that antibiotic. We're not going to say, oh, well, we got to get a culture. If they're coughing up sputum, grab it, get the culture, we're good to go. But if we can't get that culture, they're going to go ahead and start that IV antibiotic, because if we don't, we're pretty much setting them up for a certain death. Okay, so this is one of those times where, you know, you look at the situation. The NCLEX principle is you want to get that sputum specimen, you know, or urine specimen or blood cultures, all of that. Get whatever specimens you can for culture. But if we can't get that sputum specimen, they have a dry cough, there's nothing productive about it, it's not even moist, you know, we can't wait to start that antibiotic because it's going to be detrimental to the patient. Okay, so on Plato, I will post this PowerPoint. There will also be a freebie Friday that I get from this company. It focuses on ABG analysis, and it's a really nice chart. It talks about the causes of the different disorders, the respiratory acidosis, respiratory alkalosis, and the two metabolics. It talks about assessment findings you would see, as well as treatment. So that definitely is something you want to kind of take a peek at. Although remember, Unit 5 focuses on respiratory and cardiac. So you can look at the metabolic stuff, but our focus is going to be the respiratory. There is also an ABG worksheet. So there's a couple things you want to focus on with that. And again, those directions on how to interpret ABGs are also listed again on the worksheet. Interpreting the values, because you want to figure out what disorder is it? Is it respiratory acidosis? Is it respiratory alkalosis? Metabolic acidosis, metabolic alkalosis. Then you need to look, is there any type of compensation going on there? Is it uncompensated or is it compensated? If it is compensated, then the next step is for you to look at, is it fully compensated or is it partially compensated? So I want you to work through that worksheet. I do have answers to that worksheet. I'm not going to post them right away, okay? I will actually present them and then post them after the next Zoom session, because I really do want you to work through that worksheet, and work on interpreting them and seeing how you do, and then check your answers. Okay, so I'm going to stop sharing my screen and go back to the chat box now. Let me go back to where I'm at here. Prep you. Compensated. Okay. Oh, what antibiotic do they typically use if they haven't ran a sputum culture? It's going to depend on the underlying diagnosis. With your cystic fibrosis patients, because those infections tend to be multi-drug resistant and a little bit more difficult to treat, plus they've had multiple ones, they tend to go for the big guns and IV for your cystic fibrosis. For your other conditions, they'll generally start broad spectrum. So they might start with Rocephin once a day, Zithromax once a day. Sometimes they'll use a combination of that. If they're suspecting a different type of organism, I've seen them use piperacillin and tazobactam or Zosyn. I've also seen them use fluoroquinolones. It really is going to kind of depend on the risk factors. If we're thinking it is a pneumonia and the patient has been in the hospital, so we're thinking it's a healthcare associated pneumonia or it's a ventilator associated pneumonia, they're going to choose some different antibiotics based on what they believe the causative agent is likely, what the causative agent likely is. Very similar to like a UTI, where we'll start them on treatment anticipating it's probably E. coli for a UTI. And then, if we get that culture back and it's not, we may need to change that antibiotic. But typically they're going to look broad spectrum, unless they know, somebody's been exposed to something, or they were just recently treated for a pulmonary infection and this is what they were on, they'll probably put them on something else. But again, they're generally looking at broad spectrum because we want to cover as many possibilities as we can. Okay, in a COPD exacerbation, will they go back into respiratory acidosis? Well, they're always, remember, your COPD patient is always in a chronic respiratory acidosis, but it generally is compensated. When they get into an acute exacerbation, that respiratory acidosis will get worse. It will likely become uncompensated or only partially compensated. Oh, question about the diabetes project. Switching gears here. Will we be doing the video part of the project by ourselves now? Yeah, probably. I haven't really kind of thought that through. Yeah, because I don't really know how you guys would get together to do that other than trying to do something on Zoom, which would be kind of weird. So yeah, let me kind of work on that, and I'll put up some additional guidance related to that, okay? And if that means you need to change your topic, I'm okay with that. Because if you're teaching somebody at home and you selected self-blood glucose monitoring, obviously you need the equipment at home to do that. So if you live with somebody who's diabetic, hey, you're gold, you got the stuff. If you don't, you don't. So if you need to switch topics, that would be fine. Will we each be able to do a portion of the video? I don't know. Let me kind of think that through, and I'll get back to you with some guidance on that. Okay. Are there specific meds we should focus on for respiratory? Usually we do meds for our prep, and then the class PowerPoint has a more focused outline of what's important to know. Yes, so the class PowerPoint does have those medications on there along with the priority points. Again, you want to think about administration of those meds. So some of the things that we talked about today, if we're using the mucolytics and the expectorants, very important to increase fluid intake with that too, because we want to thin out those secretions so they can cough them up. Any type of inhaler, whether it's going to be nebulizer, MDI, DPI, they really should be rinsing their mouth out after that. It is absolutely critical though for your corticosteroids, for your fluticasone, you know, that class of medications, that is critical for them. But ideally you really should be doing it with all of them. Again, with the corticosteroids, the side effect of the hyperglycemia, that is a huge piece, especially with client teaching. We didn't really talk a whole lot about specific antibiotics. I know on the Unit 5 Class 2, I did have you look at azithromycin. I mainly had you do that in relation to the pneumonia case study that was involved in that particular PowerPoint, the interactive one with Lippincott. But kind of remember your basic principles of antimicrobial therapy. And I use the term antimicrobial because those same concepts generally apply to your antibiotics, as well as your antivirals, as well as your antifungals. Because if we're dealing with a viral infection, such as influenza or COVID-19, they may be using different types of antivirals. If it's a fungal infection, a fungal pneumonia, we're going to be using an antifungal. But the same principles apply to all antimicrobials. You have to take the medication as prescribed. You want to take it on time, you want to take the appropriate dose, and you want to take them till it's completely gone, okay? They need to finish the prescription. Now, other things apply in general. Unless a medication, you know, there's very few medications that have to be taken on an empty stomach. There's very few that absolutely have to be taken with food. Most of the time, it really doesn't matter. So we typically say if there's nausea and vomiting with your patient, if they're experiencing that GI upset, then to take it with food. We do know antibiotics are going to kill both good bacteria and bad bacteria, okay? So it's very, very important that they are either using a probiotic or they're also using, you know, natural probiotics through your yogurt, that sort of thing. A lot of your antibiotics will cause photosensitivity, so making sure they're not getting excessive amounts of direct sunlight, and if they are out there, they're using sunscreen. Always a goodie, an oldie but a goodie, your antibiotics will interfere with the effectiveness of oral contraceptives. Really good to tell your patients of childbearing age. That's kind of an important thing. And then of course with your antibiotics, always maintaining hydration. That's key to helping to protect the kidneys, especially for the ones that can be a little harsh on the kidneys. Where do we find the Diabetes Project link? Go into your clinical Play-Doh shell under CP3. All of that stuff you'll find under there. If a patient needs immediate O2, do you use nasal cannula? Generally, we will use nasal cannula. Obviously, if the patient is unconscious, that may not be enough. It depends on if we need actual ventilatory support where we're actually bagging the patient. With a spacer for an MDI, do they still do one puff at a time? Yes, they do, one puff at a time. They should breathe normally once they do. So they want to, when they puff it in there, they want to take a deep breath in and they want to hold it. Generally, we say for at least 10 seconds. If they can hold it longer than that, great. But that spacer is really important, particularly for kids, because they can't always, you know, coordinate the timing of pushing the MDI and their deep breath in. So that's why you'll see spacers used. and they are very effective in the sense that, you know, it helps your patient inhale more of the medication. They do need to be taught to clean their spacer. So they should be washing it out with hot soap and water, and they should just leave that to air dry. But that's really important as part of the cleaning piece. Same thing for the nebulizer equipment. That should be washed with warm soapy water or hot soapy water, left out to air dry. At home, they can use the same nebulizer equipment for quite a while. That's usually replaced by prescription. In an acute care setting, we replace the nebulizer equipment weekly. 2 minutes between puffs. In a perfect world, doesn't always happen. You really don't want to do them immediately back to back. You know, I would say at least a minute. Typically, most of your places, resources will say 1 to 2 minutes. So I would err on that, the 1 to 2 minutes. That would be, NCLEX in your Magic Hospital would say, you know, 1 to 2 minutes, 2 minutes. So I would probably stick with that. All right, I think that's all the questions. Other questions at all? I know we kind of had a really long Zoom today. I'm sorry about that. At least you guys are all here, so whoever has to listen to it or watch it later on, that'll be a long one for them. But any last minute questions at all? I don't see any. So, all right, well then we'll go ahead and sign off for here. Again, remember, as you're reviewing the respiratory content, just make sure that you're looking at it from a global perspective. Understand the intervention, understand the rationale behind it, and, you know, understand that all of your respiratory patients are going to have the same oxygenation and airway clearance interventions. The big intervention that's different is going to be how we treat the underlying cause. Yeah, so the last question that just popped up, nebulizers are replaced weekly in the acute care setting. They should be rinsed out after each use and allowed to air dry. Now remember, we're talking the Magic NCLEX hospital, not what you see in practice, okay? All right, so are we still doing a CP2 on our last SIMP? Yes, those of you who have not yet done CP2, okay, your CP2 is done on your case study that is assigned for next Wednesday, April 8th. It is the ATI real life clinical reasoning scenario, the COPD guy, I think his name is Hector Gomez or something like that. So again, if that applies to you, there's more information on the clinical Plato underneath the CP2 module there. And I will sign off. Have a great weekend and happy ABGing.